Okay, orientation terms. So distal and proximal is first. So distal, remember that distal is the end of the limb. So the fingertips are the most distal aspect of the upper limb, and the toes are the most distal aspect of the lower limb. Proximal means closer to the center of the body. So the shoulder is proximal compared to the elbow. This is called the cubital fossa, by the way. This is called the elbow. Right, the cubital fossa is distal compared to the shoulder. So if you are palpating, so if you receive a question that says a patient comes to you with a pain that's just below the attachment of the lateral deltoid on the humerus, which is right about here, would you consider this to be distal to the shoulder or proximal to the shoulder? The answer should be distal to the shoulder, because the shoulder's here. And the site that they're talking about is away from the center of the body and towards the end of the arm, away from the center of the body and towards the end of the arm. So distal, for the most part, is the center of the body and then outward along the limbs. And it's especially useful the further out you get on the limb. For the fingers and the toes, there are for the fingers and the toes. There's actually a proximal joint or a proximal phalange. So this is a finger with 1, 2, 3 phalanges. Right, so there's a proximal phalange, an intermediate phalange, and a distal phalange. Medial and lateral are more useful in discussing the orientation to the midline. So the midline of the body is here. Remember that anatomically neutral is always facing the front of the body with the palms turned like this, right? So towards the midline, all the way down to the perineum, all the way up to the vertex of the head, the midline runs. Towards the midline is more medial, and away from the midline is more lateral. So your sternum is more medial compared to your ribs are more lateral compared to your sternum. The costal cartilage of the ribs is more medial than the bones of the ribs, or the pecs, or the shoulder joints, right? The bones, the pecs, the shoulder joints are more lateral compared to the costal cartilage of the ribs. The eyes are more lateral than medial. The ears are more lateral than the eyes, right? And then if you look at the limbs, you can go proximal and distal this way, and you can go medial and lateral this way, kind of the inside and outside way of saying, right? So one place that we find this useful is the medial epicondyle, this bony protrusion here that comes off of the humerus, and there's another bony protrusion out here, which is the lateral epicondyle. And also you can speak of the medial aspect of the bicep, or the medial bicep head, lateral bicep head, right? For the hand specifically, we do say medial as in this ulnar part, and lateral as in this radial part, right? The forearm has 2 bones, right? So coming from the thumb up to the elbow, that's the radius, and from the pinky to the elbow, that's the ulna, right? So this is the lateral aspect and the medial aspect, but we also say radial and ulnar, right? So you can say medial or ulnar, lateral or radial. Then there's anterior and posterior, ventral and dorsal. So again, this is anatomically neutral. We always look at the body from this angle, right? So this is always the anterior surface, and the back is always the posterior surface. This is also called the ventral surface, and the back is the dorsal surface. For the palm and the sole of the foot, we have some specific terms. So yes, this is the anterior surface of the palm, but it's more appropriately called the palmar aspect, or also the volar, V-O-L-A-R, the volar aspect. And then the back of the hand is the dorsal aspect of the hand. And then for the foot, let's see. For the foot, we have these specialized terms, so that the back of the foot is actually, or the top of the foot, I should say, is the dorsum of the foot. And then the bottom of the foot is the plantar surface. The bottom is the plantar surface, and the top of the foot is the dorsum. Couldn't quite keep my balance there. Top of the foot is the dorsum surface. But don't get confused just because you look at the body and you can actually see the dorsum of the foot from the anterior view. That doesn't mean that it's the anterior portion of the foot, right? Okay, superior and inferior, again, two relative terms, right? So the cranium is superior compared to the cervical spine. The cervical spine is inferior to the cranium. Further down you go, the more things are inferior. The further up you go, the more things are superior, right? So in this position, for example, the cubital fossa is superior to the wrist. We would say more appropriately, we would more commonly say proximal to the wrist. But you will see people talk about the superior aspect of the humerus or of this bone or that bone. Also, for the pelvis, you see superior and inferior a lot. I mean, you see them everywhere. You see them for muscles, you see them for locations of nerves, etc. But for the pelvis, you have the anterior superior iliac spine. So that's a bump on the pelvis right here, and then just below that there's an inferior iliac spine, and then when we talk about hand, volar, foot, okay, yeah, so that's everything. Okay, that's everything for orientation. Okay, and then planes. So once we're oriented and we know where the front is, then once we know that, we understand like which way flexion is, right? And which way extension is happening, right? Because without being oriented properly to neutral, we don't know which way flexion or extension go. So this is flexion of the shoulder joint, and this happens in the sagittal plane, right? So flexion, and then coming out of flexion toward neutral, and then extension of the shoulder joint. So extension, neutral, flexion, that's all in the sagittal plane. Then also the flexion of the elbow, the flexion and extension of the wrist, flexion and extension of the elbow, flexion and extension of wrist, closing of the fingers, flexion of the fingers, extension or opening of the fingers, also flexion of the neck, and then extension of the neck. And you'll hear various terms like flexion of the head at the neck, or flexing the neck, or neck flexion. Those all mean the same things. And then also flexion of the thoracic spine, flexion of the lumbar spine, extension of the lumbar spine, extension of the thoracic spine. There's also an extension and a flexion of, extension and a flexion of the hip joint. And then there's extension of the hip joint with the foot off the ground, and flexion of the hip joint with the foot on the ground. We also have the flexion and the extension of the knee, and then plantar flexion and dorsiflexion of the foot. Those are all within the sagittal plane, One of our colleagues is having a little confusion getting in. So thank you, Khalik, for messaging that person. I'm just going to make sure that person gets in. I won't be doing this all the time. You know, if people have trouble getting in after the first couple times, it's on them. I don't stop to. By the way, remember guys, that Zoom link for the meeting, it's also in your basics document. So the document that I'm sharing with you guys, titled MBLEx March 2023 Basics, it's also in that document. Yeah. Okay, so we did flexion and extension of, I think, all the joints, I think. So let's do abduction and adduction. So AB, I want you to say when you're taking the test and when you move in general, I want you to say abduction and adduction. So abduction is abducting away from the midline. Here's the midline. right? And if you go all the way up, you reach the vertex of the head. Please mute yourself, whoever's unmuted, and make sure that your camera is off. And then adduction is bringing the limb toward the midline. So this is adduction. This is abduction. So abduction and adduction. Through the shoulder, right? Abduction, adduction, and then through the hip joint, abduction, and then adduction, adding adducting to the midline, and then abducting away from the midline. And your adductors are the adductor magnus, adductor longus, the pectineus, etc. And those are on the inside to bring the limbs toward the midline. And the abductors are on the outside, the TFL, the gluteus minimus, and those serve to take the limb away from the midline, abduction and adduction. For the shoulder, there's a special term when the limb is moving through the horizontal or the transverse plane, and that is horizontal adduction, horizontal abduction. It's also called cross flexion. Sometimes I've seen it written that way. Okay, supination versus pronation. So supination is with the palms up or with the ventral surface of the body facing up. So when someone lays on their back on your massage table and they're facing up, that's supination. When they turn over and put their face in the face cradle and they're laying belly down, face down, that's pronation. Okay, I'm just going to let this. Okay, everyone, please keep your cameras off. And when you enter, please mute yourselves. Maybe I will configure the meeting so that people can just come in. Try not to be so late, and also in the future, I may not be able to stop what I'm doing and let you in like right if you're late, I may not be able to let you in right away. It may take me a few minutes to get to a natural pause to let you in. As you can tell, the rhythm is already kind of broken. Okay, so supination, pronation, right? So belly up, face up, that's supination. Belly down, face down on the massage table, that's prone. And I like to remember supination as in carrying a bowl of soup, and I would remember prone as in prone to spilling the bowl of soup. There's also supination and pronation in the feet. So supination in the foot actually looks like this. I'll show you closer when we get to inversion and eversion. And I like to think of supination of the foot as in, if I were to keep rotating my femur, the bottom surface, the plantar surface of the foot would start to face up as in approaching supine. And then pronation is, I think of it as the medial surface of the foot starting to press down into the floor, which is what happens with eversion. Supination and pronation, you can expect to be asked about those on the MBLEx for sure. Okay, protraction, retraction, elevation, and depression. So protraction is shoulder blades apart. Retraction is the shoulder blades together. Please do these movements with me and say the words so you start to get really well versed in these. Protraction is the shoulder blades apart, and then retraction is the shoulder blades together. Elevation is the shoulder blades up, and then depression is the shoulder blades down. When you depress, you should feel your latissimus dorsi muscles and your lower traps, your lats, pulling the shoulder blades down. When you elevate, you should feel your upper trapezius muscles pulling the shoulder blades up. When you protract, you should feel You should feel your lats into, and also this muscle in here, the serratus anterior, starting to pull the shoulder blades forward. And when you retract, you should feel the rhomboids and the serratus posterior superior should feel those, and the middle traps starting to squeeze together. Inversion and eversion, medial lateral. Let's do inversion for the foot in a minute, because that requires that I tilt the camera down. Okay, medial lateral rotation, internal external rotation. Yes, so inversion, so medial and lateral rotation. So medial rotation goes towards the midline, lateral rotation goes away from the midline. When I bend my elbow at 90 degrees like this, I can tell really easily which way the humerus is moving, because the arm acts like a needle, like a pointer, right? It's also called internal rotation and external rotation. I prefer those terms, just personal preference, no reason beyond that. But if you look at your humerus and you draw a line, like a circle around your humerus, or a band around your humerus, you can see that the humerus is internally rotating or rotating toward the midline, externally rotating toward away from the midline. And if you straighten your arm and look at your humerus, you still can see internal rotation and external rotation, internal and external rotation. And then no matter what angle you put your humerus in, internal and external rotation should always make sense to you, no matter what degree of flexion or extension the elbow joint is in. Still, internal and external rotation should make sense to you, right? Even if your hand is up in a W, which is a common position for people to train the sits muscles, external rotation and internal rotation. So it should be clear if you're looking at the humerus, right? Even if the arm is up over in a Y position, it's still external rotation and internal rotation. Two of the most common positions for the shoulder for external rotation that I've seen in MBLEx practice questions are with the elbow, or with the arm adducted to the side. So I'm adducting. This is abduction. This is abduction. This is adduction. Right, the elbow at 90 degrees. So the humerus is adducted. The elbow is at 90 degrees. And the question usually is something like, a person with a shoulder injury, recent shoulder injury, has the humerus adducted and the elbow at 90 degrees, and they're pressing the back of the wrist into a wall. And they want to know, is this an isometric, isotonic, concentric, or eccentric? And they want to know which muscle is being worked. Well, it's an isometric which we'll get into at some point, because you're pressing into a wall, something immovable. So the length of the muscle doesn't change. The muscle doesn't shorten. It shortens when the humerus starts to move, and it lengthens when the humerus comes back toward internal rotation. And the muscle that's actually doing external rotation at the shoulder is the infraspinatus. That's definitely something that you should know. Infraspinatus muscle. And against something that is an immovable object like a wall, it's isometric. Dorsiflexion, plantar flexion, wrist radial deviation, and ulnar deviation. I think we covered radial deviation and ulnar deviation already. So ulnar deviation looks like this. Radial deviation looks like that. Ulnar deviation would also be moving toward the midline from an anatomically neutral position. So that's called adduction. Radial deviation is moving away from the midline from an anatomically neutral position. So that's called abduction. So ulnar deviation, adduction, radial deviation, abduction. While we're still at the neck and spine, let's look at lateral flexion. So lateral flexion looks like this, also called side flexion through the rest of the spine. It looks like that, right? And one more for the shoulder, diagonal abduction. So we did a horizontal abduction, horizontal abduction. Now we're doing diagonal abduction, diagonal adduction. Circumduction. Circumduction is where the distal end of the limb makes a large circle, and the proximal end of the limb rotates around a point, right? And you can think of this as making like a cone shape, or some call it a Christmas tree shape. There's an aspect of moving toward the midline and moving away from the midline. So that's adduction and then abduction. There's also moving down to 6 o'clock and moving up to 12 o'clock. So that's extension and flexion. And sometimes they will add rotation into supination, rotation into pronation. So then you have 6 movements altogether. You have flexion, abduction, rotation into pronation, and then extension toward neutral, adduction, and then supination toward extension. Then the lower body, especially the foot. Hopefully you can see the foot okay. All right, so so the foot has plantar flexion and then dorsiflexion. Plantar flexion is flexion toward the plantar surface, right? So I'm going toward the plantar surface. And on the back of the foot, the top of the foot rather, is the dorsum. So this is dorsiflexion, dorsiflexion, and plantar flexion. All right, and then there, we saw earlier that there's supination and there's pronation, right? Supination and then pronation. Now, this movement is called inversion, and there are 3 movements to it. There's supination, the supination aspect. There's adduction toward the midline, so that's supination, and then adduction. And there's also a little bit of plantar flexion. So supination, adduction, plantar flexion creates inversion. Inversion. And then eversion going toward the outside has a little bit of pronation, a little bit of abduction, and a little bit of dorsiflexion. So dorsiflexion, abduction, and then pronation. And that's eversion. So the inversion of the ankle is what we think of as rolling the ankle. That's much more common in an ankle injury. But eversion does happen too. So eversion looks like this, and inversion looks like this. And you can imagine, you have to think about these things. You can imagine that with an inversion ankle sprain, you're overstretching structures on the outside, on the lateral surface of the lower leg, all the muscles and tendons and ligaments and joints. And on eversion, you're overstretching the structures on the inside of the ankle, all the way down into the toe and up into the medial aspect of the lower leg. By the way, the leg is said to have 2 sections. The arm is said to have 2 sections. So there's the upper leg, the lower leg, right? So upper leg, lower leg. Usually people don't call it the upper leg, they just call it the femur. I think that's just how we say it, right? But it is the upper and lower leg, and together they make up the lower limb. The upper limb is the arm, and the arm has the upper arm and the lower arm. Usually people say the forearm. Sometimes you hear it referred to as the upper arm. Usually they just call it the humerus, but it's upper arm, lower arm, humerus, forearm, upper leg, upper limb, lower limb. And I think that is good. Yeah, that's gonna do it for today. For the orientations. All right. Okay, so now we will move into working on some of our study points. And those are the points that the FSMTB wants us to prepare for the MBLEx. Guys, remember that this document, MBLEx March 2023 Basics, how about I just call it MBLEx Basics, all right? So for the MBLEx Basics, there's a Zoom link at the top of the page, right? That way, nobody has to text you in the beginning of class saying, hey, we're over here. And by the way, I'm usually that person going, where are we again? Okay, so let's look at, what are we going to look at today? Yeah, let's start. Yeah, let's start here. So if you go into the MBLEx drive and you look at, let's refresh this because I don't think it's updated yet. you look for a slides presentation. Those are the documents in yellow. And you go down to K for kinesio. You will find tonight's document, which is called Proprioception, Components and Characteristics of Muscles. So where's that, by the way? Oh, no, I should move this. Okay, here. And move. Yes, I'm sorry, I didn't have it. I had it in a different folder. Kinesio, proprioception, components and characteristics of muscles. If you look at the FSMTB e-study guide for kinesiology, which is right here, you'll find the learning objectives, which I haven't uploaded in with green check marks yet, but I will. So these sections in kinesiology, they have components and characteristics of muscles, which we're going to do tonight one by one. They have concepts of muscle contractions, which we're going to do probably next week. We might get to it tonight. Tonight we're also going to do. I think we're going to do proprioception tonight, and then locations, attachments, origins, actions, and fiber directions. We're going to start to get into some of that tonight. So we're really going to be focusing on components and characteristics of muscles. And let me read to you the description of kinesiology as the FSMTB puts it. So the content of the kinesiology section of the MBLEx is focused on assessing the candidate's knowledge, understanding, and application of the basic concepts of movement in the body. MBLEx items will be called upon candidate's ability to test this knowledge to dissect the exam questions and determine the correct answer. Knowledge of how kinesiology overlaps with anatomy and physiology with regards to the muscular, nervous, and skeletal systems will be beneficial. The candidate preparing for the MBLEx is not expected to name actions, attachment sites, and innervation for every muscle in the body. You will be asked to name them for many of the muscles, but not every muscle. Candidates will always benefit from strong knowledge of muscular anatomy. Understanding the mechanics of muscle interaction will be more important than memorization of all the muscle attachment sites. Muscle interaction. So how does the anterior deltoid and the bicep, how do they work together in shoulder flexion and raising the shoulder? Are they synergists with each other, or do they antagonize each other, or is one just irrelevant to the other one, right? Stuff like that. Is the posterior deltoid an agonist or antagonist to the anterior deltoid? And if so, for what movements, stuff like that, rather than all the muscle attachment sites. A candidate should have an understanding of kinesiology tools like the application of range of motion, assessing and reassessing joint mobility to support treatment planning. All right, proprioception, components and characteristics of muscles. Let's see, we have proprioceptors listed first. Components and characteristics of muscles. We should start with components and characteristics of, I guess it really doesn't matter. All right, we'll start with proprioception first. What the heck? Please let me know if you cannot see the screen. All right, I'm going to make it bigger. So our study points are to understand the locations and the functions of the proprioceptors. When the MBLEx says proprioceptors, what they're talking about are the sensory organs inside the muscles and the tendons that help with proprioception. Those are the muscle spindle fibers, more specifically the intrafusal muscle spindle fibers, and also the Golgi tendon organs. Proprioception means your literal like feeling, kinesthetic sense of where your body is in space, where your head and eyes and your body are relative to the horizon. So proprioception is what tells you you're about to fall or you are falling, and tells you to initiate a reflex to put your hands out to catch yourself so you don't hit your head on the ground. Proprioception also tells you about the angle of the bones. So proprioception tells you when your elbow is at 90 degrees of flexion, provided that you practice 90 degrees of flexion, provided that you practice those kinds of things consciously on a regular basis. If you practice things unconsciously, and you'll see this in your clients, your proprioception will reset and it'll be uncalibrated, it'll be off. So in my neck, because I have like some old herniated discs, I learned the habit laterally flexing my neck to the right. So my proprioception is off. I usually feel that this is neutral. I feel that this is neutral. And if I correct to neutral, it takes me a while to reset the sense of that being zero. And you'll see that with clients quite often. Don't be surprised if there's a question on the MBLEx about that. Yeah, we'll get to the sample question later. Demonstrate the ability to differentiate between the two types of proprioceptors. So knowing the difference between muscle spindle fibers, intrafusal muscle spindle fibers, and Golgi tendon organs. What kind of reflexes do they initiate? Where are they? What's the differences in function? Before we begin, I just want to remind you that in terms of anatomy and physiology, what we're talking about with muscles are how they're built, the structure, and then the physiology really is how they fire and how they function. And then overall, there are 12, maybe 11 systems, right? So some call them body systems, some call them the 12 systems, right? So a body system is anything that has an organ or specific parts to it, like where's the lymphatic system? Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Lymphatic, maybe lymphatic is included in circulatory. Okay, so as you can see, there's more than one way to organize these, right? And we could say that there are 12 body systems, and we can include lymphatic as we could say that lymphatic is included, for example, in the circulatory and in the immune system, or we could say that lymphatic is its own system. We also could say that immune is not a body system, that the immune system is not a body system because it doesn't have any specific organs, you know, unlike the circulatory cardiovascular system, the lymphatic system, those have specific structures meant to move lymph, move blood, but the immune system is more of a system through its coordinated functions across many body systems. So it's not really important. I just want you guys to understand for the MBLEx, if you see 11 systems and you're expecting 12, or if you see 12 and you're expecting 11 or 13, that it's flexible. And lots of things, there are lots of gray areas in anatomy, physiology, and kinesiology. There's many places where there's disagreement. And part of my job is to help you focus on the stuff that's more definitive, that's agreed on, and take the gray stuff and simply be aware of it, but not focus on it so much. So if you look at the structure of a muscle, this is what's called the gross structure. There's gross structure, which is like the big aspect, and then there's the microscopic structure. So you have the macro or the gross, and the macro or gross, and you have the micro. At the microscopic level, you also have histology, which is histology is the study of the tissues, right? So how the cells organize into specific shapes and how the shapes organize with each other, and you know, what is a fascicle, what is a fiber, what is a muscle belly. So here you see a muscle belly, and this white part down here is a tendon. And what they have done is they have cut the belly, and they've inserted kind of a grabbing tool, two grabbing tools, and they've pried the belly apart along the incision. And if you do that inside, you would see, supposedly, you would see what's called a spindle. The spindle is like a structure that holds fibers inside and separates the inner fibers from the outer fibers. The inner fibers inside the spindle are called intrafusal, and the fibers on the outside are called extrafusal. The extrafusal fibers are the ones that we think of as the muscle belly proper. So that's like the majority of the fibers in a muscle are extrafusal muscle fibers. The extrafusal muscle fibers create the strength of the muscle, the force of the muscle, and the extrafusal fibers also create the size of the muscle. The intrafusal muscle fiber, the extrafusal muscle fibers, they also, because they contract and relax, they are motor in nature. They are movement in nature. The intrafusal muscle spindle fibers on the inside, the intrafusal fibers, they are, on the other hand, not motor, but sensory. And their job is to sense the amount of stretch that a muscle is undergoing, as well as the speed of stretch. So it's the amount of stretch and the rate of stretch. Can somebody unmute and tell me, why would it be important to sense the amount of stretch or lengthening or the rate of stretch in a muscle? Why would that be important for us?
So you don't overstretch it?
One more time, please.
So you don't overstretch it?
So you don't overstretch, yeah. And what can happen if you overstretch?
Like, can't you like tear it?
You can tear. That's right. You can tear, definitely. And are you aware also that stretching or lengthening is a normal part of muscle function? Like some muscles have to lengthen so that others can contract, the antagonist-agonist relationship. Are you aware of that?
Yes.
So then you probably can envision how basic movements like walking, where the front surface is contracting, necessitates the back surface to stretch, and it has to relax to stretch, right? Running even more so, yeah? So some of our basic functions, they have to allow us to lengthen the fibers in order for us just to get from point A to point A. Thank you very much. Please mute yourself. So the extrafusal fibers, they're the ones that contract and lengthen in order to give us our motor capacity, our motor function. The intrafusal fibers, they regulate how much the extrafusal fibers will be allowed to lengthen and how much they are required to contract. The Golgi tendon organs do something similar, but they don't do it with stretch. They do it with the amount of force, the amount of load. And we'll discuss the Golgi tendon organs after we discuss the extrafusal and intrafusal fibers. When you hear extrafusal muscle fibers, I want you to think motor, right? So you can call them the extrafusal motor fibers, the motor extrafusal muscle fibers. They receive their impulses from efferent nerves. Efferent means the impulses exit the central nervous system and they go down through the body into the muscle, right? So they exit the central nervous system, letter E, that's efferent. And the intrafusal muscle spindle fibers, they have a sensory capacity. So when you hear intrafusal, in terms of muscle, I want you to think sensory intrafusal muscle spindle fibers. I also have seen these in some review questions written as intrafusal muscle cells. So, you know, when you see like a 3 or 4 word term like intrafusal muscle spindle fibers, and they sub out one of those words, just go with the majority or with the most important word that you know what it is, whose definition you know. If intrafusal in there is in there, that pretty much, that refers to only one structure in the entire body. It refers to the muscle fibers that are inside the muscle spindle. And I want you to recall at that point that they're sensory in nature, that they detect stretch and the rate of stretch, and they receive their impulses from the afferent nerves, or they send impulses through the afferent nerves. They don't receive impulses through afferent nerves. I'm sorry, they send impulses to the central nervous system through afferent sensory nerves. The sensory nerves are by their nature afferent because they take the information from the muscle, from the area that they're sensing, and they send it toward the nervous system, and it arrives toward the central nervous system. It arrives, letter A for afferent, it arrives at the central nervous system. So they're called afferent fibers. Yeah, we already went over this part of it. So extrafusal muscle fibers, also called efferent motor extrafusal muscle fibers. They are the largest part of the muscle and they're the main source of strength for the muscle. Intrafusal fibers, which you can think of as afferent, sensory intrafusal muscle spindle fibers, their job is to sense stretch. That means the amount of stretch as well as the rate of the stretch. Yeah. Okay. We can kind of skip the stats. In fact, these aren't like really very helpful because this compares the number in the entire body to the amount per muscle. I guess I'm just going to take that out now, actually. I'll leave it like that. One quote that I like from Science Direct is that muscle spindles or intrafusal muscle spindles it's talking about are proprioceptors that consist of intrafusal muscle fibers enclosed in a sheath or in a spindle. They're parallel to the extrafusal muscle fibers and act as receptors that provide information on muscle length and the rate of change in muscle length. The spindles are stretched when the muscle lengthens. Yeah. And there's a link there if you want to go read the whole thing. Okay, so how do intrafusal fibers, intrafusal muscle spindle fibers, how do they help us function in the body? If a muscle is being stretched, maybe suddenly stretched, in the case of hitting a hammer on the patellar tendon, you're actually stretching the rectus. I always confuse rectus and biceps. So rectus femoris, rectus is in the front. The biceps are two heads, so those are in the back, because I remember the hamstring has two heads on the inside, two heads on the outside. So the biceps must be in the back in the hamstrings, and the rectus must be in the front. So if you strike the patellar tendon with a rubber mallet, it deforms, presses, or stretches the patellar tendon, which deforms and stretches part of the rectus femoris muscle. And the muscle spindle, the intrafusal fibers in the muscle spindle, they sense that stretch happening. They send an impulse through an afferent neuron or through afferent nerve fibers. They send an afferent impulse into the central nervous system. This is your spinal cord, a cross section of your spinal cord. And the afferent impulses arrive at the central nervous system. And then the central nervous system relays a motor impulse back out through efferent fibers, efferent, letter E for exiting the central nervous system. Efferent motor impulses exit the central nervous system, and they stimulate the rectus femoris to contract. So initially, the rectus femoris is being stretched by the striking of the mallet, and the response, the reflex is for the rectus femoris to contract, to shorten. It shortens in response to lengthening or to stretch. In order for the rectus femoris to shorten, the biceps muscles have to allow the rectus femoris to shorten. So the biceps have to contract. They have to be inhibited. So when the antagonist, the hamstrings are the antagonists to the rectus femoris. When the antagonist is inhibited by a process beginning with a stretch, with the stretch, the process is called reciprocal inhibition. So the muscle which is on the other side is inhibited through reciprocal inhibition. We'll see later, we'll see in a minute, a process where the same muscle that's being loaded or stretched is inhibited, and that's called agonist inhibition. Reciprocal inhibition or antagonist inhibition also involves the activation of the rectus femoris. So you guys repeat some of these phrases with me. When the rectus femoris contracts, that's also called activation. So the rectus femoris is being activated. Say that the rectus femoris is being activated, and the hamstring is being inhibited. The hamstring is being inhibited. The rectus femoris is being activated. Rectus femoris is the agonist. It's being stretched and then it contracts. It's the one that contracts. It's the agonist. The hamstrings are the antagonist to the rectus femoris. So you have rectus femoris and rectus femoris agonist, which is being activated and contracts. And then you have the hamstring, the antagonist, which is being inhibited and it relaxes. And again, the sensory information goes from the forgetting my terms now, the is it intrafusal or infrafusal? Man, how many times have I taught this stuff? The intrafusal muscle spindle fibers, the stretch sensation goes from the intrafusal muscle spindle fibers through an afferent neuron that arrives at the central nervous system. Then the central nervous system relays an efferent motor impulse back to the rectus femoris. The central nervous system relays an efferent motor impulse back to the rectus femoris. It also relays an efferent motor impulse to the hamstrings, telling them to relax or to inhibit. Okay, so I would like you to unmute and let me know if you are confused. If you are confused, please unmute and let me know. And it is never too late to do that. So this slide's just reminding you about afferent and efferent, right? So afferent arrives at the central nervous system, and through repetition, you will get used to associating the word afferent with sensory, because that's what it is. So it's sensory impulses travel through afferent nerves that arrive at the central nervous system. And then motor impulses travel through efferent nerves that exit the central nervous system. Motor impulses travel through efferent nerves that exit the central nervous system. Motor impulses and efferent nerves, they don't just go to muscles, they go to all tissues that are to receive a command and do something. So they could go to sweat glands, they could go to the muscles in the eyes or the skeletal muscles, they could go to glands in order to create hormones or excrete hormones. They may go to the gallbladder to create and secrete bile. They might go to sweat glands. But efferent impulses, they go to what are called effector tissues. All of these are effector tissues. Anything that is supposed to receive a message from the central nervous system and react or do something is an effector tissue that receives its messages through efferent fibers, motor fibers, efferent fibers. And some of these are somatic, like the muscles are part of the soma part of the body. And some of them are visceral, part of the organs, the visceral part of the body. And some of the fibers, some of the motor fibers are autonomic, meaning the unconscious, the non-conscious effort of the body to control homeostasis. So, anything inside that we don't have to control, like the endocrine glands, the digestive organs, the sweat glands, etc. All those are controlled by efferent motor fibers, which are also autonomic. And then the somatic nervous system, meaning the muscles and tendons, bones, etc. Those are all controlled by somatic fibers, still efferent, still motor. Okay, if I say things many, many, many times, it's just because I want you to hear the word over and over and over again. I know that some of you have heard this a lot. Others might not have heard it at all. I know that some people arrive never having really heard the word afferent letter A or efferent letter E. Or if they have, it wasn't explained to them, or they didn't remember it. Okay, guys, unmute. Everybody unmute, and let's identify some of the structures. So this big red part, what is that called? The bulk of the muscle is called what?
Belly.
The belly, yeah, that's right. And what's the name of the fibers in the belly?
Muscle spindles.
Okay, this here is the spindle.
Oh, that's the spindle. Okay.
The structure here is the spindle, yeah. Okay, so if you're outside the spindle, if the fibers are outside the spindle, what are they called? Intra or extra?
Extra.
And is it extra spindle, extra?
I forget.
Okay, extrafusal. Yeah, okay, so someone else now. What are the fibers inside the spindle called?
What, intrafusal?
Intrafusal, that's right. Which ones are the sensory fibers? Intrafusal or extrafusal?
Intra.
Intra.
Intrafusal, yeah, that's right. Okay, someone else now. So the sensory nerves that come from the intrafusal muscle spindle fibers, are they afferent or efferent?
Can you
Do
repeat
they
that?
send,
Afferent.
do they, yes, they are afferent. So to repeat the question, the sensory nerves that carry impulses from the intrafusal muscle spindle fibers, are those sensory nerves afferent or efferent? Do they arrive at the nervous system, or do they exit the nervous system? Do they have impulses that arrive at the central nervous system, or do their impulses exit the central nervous system and go to effector tissues?
Arrive.
Arrive. So then afferent, letter A. Okay, great. This is another, you guys can mute yourselves again, please. Thank you. So this is another, just another drawing of muscle belly, also called a muscle gaster. Bellies are also called gasters. And you have the fibers on the outside of the muscle spindle. You have the spindle here in kind of orange, and then you have the fibers on the inside. So on the inside are the intrafusal fibers. On the outside are the extrafusal fibers. The intrafusal fibers are separated from the extrafusal fibers by the spindle. Yet another drawing with extrafusal fibers on the outside, the muscle spindle in kind of yellow orange, and then the intrafusal fibers on the inside. And there's, sensory, what looks like sensory, the arrows pointing this way, away from the muscle. So sensory nerves, and then motor nerves carrying efferent, letter E, impulses, and sensory carrying afferent, letter A. And the intrafusal fibers, they sense stretch and the speed of stretch. And here's a link if you want to go to the University of New Mexico article that I took that from. Okay, guys, how confused are we? Are you guys like totally confused about muscle spindle fibers, intrafusal muscle spindle fibers, and reciprocal inhibition? Or is it like an afferent and efferent, or is it, more or less clear? Okay, so sounds like, what's that?
I said, I feel like it's clear.
Okay, great. All right, so now let's move on to the Golgi tendon organs. So these Golgi tendon organs, there can be, I think, hundreds or thousands of nerve endings, like axon terminals in the tendons, functioning as Golgi tendon organs. And their role is to sense the amount of force. So, force is, I don't want to get too complicated, but force is both weight and it's the distance or the speed at which that weight travels. So the body will not initiate a reflex to control the muscles if you pick up something slowly, or if you grab something and try to pick it up slowly, it won't initiate the same reflex as if I toss it to you and you catch it. Your body will function differently. It'll get different messages. If the weight is heavy enough, or if the weight is traveling in such a way that your nervous system thinks you can't control, it'll force you to drop it, or it won't allow you to pick it up in the first place. And that is the role of the Golgi tendon organ. There's a good video that I'll just show you. And the point of the video is, the point of the video is to show you how the nervous system says nope and shuts down muscle contraction when the Golgi tendon organs send sensation about force that may be too heavy for the body. So what you're going to see is, you're going to see this individual, Max Aita. You're going to see him squat down with like 600 pounds, 270 kilograms on his back. And when he gets to the bottom, he's going to try to stand up. And his nervous system, through the Golgi tendon organ initiated autogenic agonist inhibition, the central nervous system is going to tell his rectus femoris, his thigh muscles, to shut off, and he's going to not be able to stand up.
Warm up.
right there. See, he tries to stand up and he does, and he misses it. It's called a miss. Nope. And they help him up. So, all right, let's see here. How come this thing is so, you would think all the times that I've done this, that I would know how to drive this thing, this so-called MacBook. But still I do not. Okay, so the mechanism by which that happens is called autogenic inhibition. It's very similar to reciprocal inhibition. It's just the agonist, which is inhibited. I think I said agonistic inhibition. That's not correct. It's autogenic inhibition. I need to brush up on these terms myself too, like all the time. So Golgi tendon organs inside the tendons of the muscles. Remember that tendons connect the muscle to the bone. They hold the muscle to the bone. Their job is to sense force, also sometimes called stretch force, and to inhibit the contraction in the same muscle, or the agonist, right? So in Max Aida's case, it was the rectus femoris. And the rectus femoris was the muscle contracting in order to straighten his legs so that he could stand up, right? And autogenic inhibition doesn't happen just as a result of the amount of weight being lifted or moved one time. It can happen as a result of fatigue, right? So if you've ever picked up something that was that was easy for you to pick up, like, which one of us has not had to move boxes and furniture moving from one apartment or one home to another? That first box, it's like, okay, I think I can probably do that. But by the end of the day, like it gets really, really hard to lift those boxes. And sometimes you can't lift anymore and you have to take a break, or maybe even that's it for the day. So fatigue can do it. Fatigue can overload the muscles. And it's the job of the Golgi tendon organs to sense when the muscles are being overloaded, either through one heavy weight or through a manageable weight lifted or moved several times. So let's go down to, we did reciprocal inhibition. Let's go down to autogenic inhibition. It looks like I don't have I'm sorry, it looks like I don't have a graphic for the rectus femoris muscle. So I'm going to just show you the rectus femoris muscle. And let's see if I can find one in a squat. Yeah, here's one. So that it's the job, if you think about it, or if you look at your rectus femoris, that it's the job of the rectus femoris muscle to flex, to extend the knee, right? And it should sort of make sense to you, right? Because it crosses the knee joint. I know it looks like it ends at the patella, but by virtue of the fibers of the tendons meeting the prepatellar tendon, and then there being a patellar tendon that attaches to the tibia, the fibers of the connective tissue, the fibers of the tendon of the rectus femoris are actually connecting to the tibia. So it connects to the lower leg. And you can imagine that if the fibers insert here, or they start at the pelvis and they attach down here onto the tibia, you can imagine that this joint here, with more movement than the top, this joint here would be the main one that moves. So the leg is going to swing, the lower leg is going to swing like this. It's going to flex and extend as the rectus femoris relaxes and then contracts, right? So the rectus femoris starts to relax or contracts eccentrically, depending on what's happening. And as that happens, the knee starts to bend. It allows the knee to bend, and the person ends up in a squat, right? And the knee is flexed. And as the rectus femoris starts to contract, or as we start to stand up, the rectus femoris contracts, and then the lower leg starts to extend, it starts to extend, and then the knee joint straightens. Okay, guys, I need to take a bio break and also say goodbye to my partner who's going out for work. So I'm going to pause at this point. You guys come back at 7:14. 7:14 Eastern time. Come back at 7:14 Eastern time. We'll pick up right where we left off. Thank you. So reciprocal inhibition versus autogenic inhibition. You guys go ahead and unmute yourselves. Let's drill this a little bit. So reciprocal inhibition, if we're looking at the stretch of the rectus femoris muscle, which muscle would be inhibited? The rectus femoris or the antagonist hamstring? Okay, someone has quite a lot of extraneous sound in the back. So guys, I would like you to try to answer these questions with me. Can I see like 8 people in the room, and 1, 2, 3, 4 of them are unmuted. So I'm going to ask each of you to unmute, sending like a notice to unmute. So if you guys could unmute and participate, that would be awesome. So I'm wondering, I want you guys to practice distinguishing between reciprocal inhibition and autogenic inhibition. So with reciprocal inhibition, if we're talking about the rectus femoris muscle, which muscle would be inhibited? Would it be the rectus femoris or would it be the hamstring?
Hamstring.
Yes, the hamstring. And that's again for what? Reciprocal or autogenic inhibition?
Autogenic.
Reciprocal.
So autogenic would reciprocal, that's right. So autogenic would be when the main like prime mover is inhibited.
Mhm.
And if we're talking about standing up from a squat, if we're talking about the rectus femoris, the rectus femoris then is the agonist. So what if the nervous system is telling the rectus femoris not to contract or to let go? It's inhibiting the rectus femoris. Is that called autogenic inhibition or reciprocal inhibition?
That was autogenic.
That's
it the auto?
autogenic inhibition.
Okay.
Yes, autogenic inhibition. Yeah. So which one? So reciprocal inhibition results in the inhibition of which muscle? An agonist or an antagonist?
Is it the antagonist?
The antagonist, correct. Now someone else. So autogenic inhibition must result in the inhibition of what? The inhibition of what? The agonist or antagonist? Autogenic. Agonist or antagonist? Agonist. Did you say agonist or antagonist? Okay, so one more time, guys. So autogenic inhibition results in the inhibition of which muscle? The agonist or the antagonist?
Agonist.
The agonist, that's correct. Okay, now someone else. Reciprocal inhibition results in the activation of which muscle? Reciprocal inhibition results in the activation of which muscle? The agonist or the antagonist?
Antagonist.
Anyone else? So activation, Khalik, means contraction. So in reciprocal inhibition, which muscle is being inhibited? Khalik.
All right, repeat that one more time.
Yes, in reciprocal inhibition, which muscle is being inhibited? The agonist or antagonist?
Agonist.
The antagonist, the antagonist. Okay, everybody mute yourselves and repeat after me. Everybody mute yourselves and repeat after me. Reciprocal inhibition inhibits the antagonist. Reciprocal inhibition inhibits the antagonist. Reciprocal inhibition inhibits the antagonist. Reciprocal inhibition activates the agonist. Reciprocal inhibition activates the agonist. Reciprocal inhibition activates the agonist. So if you can now sit down into a squat, lower yourself down into a squat, and put your one hand on the rectus femoris and one hand on the hamstring and start to stand up. And reciprocal inhibition is inhibiting the hamstring. Go back down into a squat and stand up again. Reciprocal inhibition is activating the rectus femoris. One more time, go down into a squat. Reciprocal inhibition is inhibiting the hamstring, inhibiting the antagonist. And last time, going from bottom to top in the squat, reciprocal inhibition is activating the agonist, the rectus femoris. Hopefully that helps. Okay, let's see if you guys are any sharper. Who shall I choose? How about Khalik? Hello. So reciprocal inhibition inhibits which muscle, Khalik? The antagonist or the agonist?
You said the antagonist, right?
I'm asking if
Relax it.
reciprocal inhibition inhibits or relaxes. Yes. The antagonist or agonist.
Yeah. I'm gonna say relaxes. Relaxes.
Which one, Ed? You gotta pick one, man, you know?
Relaxes the agonist.
Relaxes the antagonist. Okay,
I was gonna say that.
two call and response rounds. Two call and response rounds for you, okay? I'm the preacher, you're the choir. Reciprocal inhibition inhibits the antagonist. You try.
Inhibits the antagonist.
Right.
Okay.
Reciprocal inhibition inhibits the antagonist.
Uh-huh.
Come on, reciprocal inhibition.
Reciprocal inhibition.
Yes, close enough. Inhibits the antagonist.
Antagonist.
Very good. One more time. Reciprocal inhibition inhibits.
Reciprocal inhibits the antagonist.
Very good. Very good. And reciprocal inhibition activates the agonist.
Reciprocal inhibit. You said it activates the agonist, right?
Perfect. Perfect. Last time. Reciprocal inhibition activates the agonist.
Reciprocal inhibition
Activates
the agonist.
the agonist. That's right. Okay, great, Khalik. Thank you very much.
So
Everybody,
relaxes the antagonist.
yes,
Got it. Okay.
and activates the agonist.
All right.
Is that enough? Sounds like you might want to go again. You want to do it again?
Yeah.
Okay. All right. So if you are, let's pick a different body area. Okay. Let's do the glutes and the hip flexors. All right. So if you're down in the bottom of the squat and you're starting to stand up, the glutes are going to contract or shorten and the hip flexor is going to relax or lengthen. Can we agree on that? Can we agree on that?
You said in a squat.
If you're down at the bottom and you're starting to stand up, the glutes are going to shorten and the hip flexor is going to lengthen, right? So the glutes are the agonist and the hip flexors are the antagonist.
Correct.
Can we agree on that? Okay,
Yeah.
so if reciprocal inhibition happens between the glutes and the antagonist, between the glutes and the hamstring, between the glutes and the hip flexor, which one will be inhibited in reciprocal inhibition, the antagonist or the agonist?
Antagonist.
Antagonist, yes. Khalik, how did you change your voice like that? So sweet. So if the antagonist is going to be inhibited, which one will be inhibited, Khalik? The hip flexor or the glute?
The glute.
The hip flexor. Standing up, the glute is the agonist, and the
Mhm.
hip flexor is the antagonist. Okay, let's look at a simpler example. So the biceps brachii muscle and the tricep, all right, doing a curl, flexing or contracting or shortening which muscle?
Your bicep. You shortening your bicep.
The bicep, shortening the bicep. So if
your
reciprocal
tricep.
inhibition, go ahead.
Your tricep is relaxing.
That's
So
right.
flexing.
So yes, correct. So in reciprocal inhibition between the bicep and the tricep in a curl, which muscle is being inhibited? The antagonist or the agonist? In reciprocal inhibition, the antagonist is inhibited.
You said the antagonist? The antagonist is the
Antagonist.
tricep.
That's right. But have you noticed in all three examples with the hamstring and the hip flexors and the tricep, I'm not asking you for the name of the muscle. I'm asking you for antagonist versus agonist.
Got it.
Yes. Don't let the smaller details trip you up. In reciprocal inhibition, the antagonist is inhibited and the agonist is activated. Okay, Khalik, every time we do agonist, antagonist, inhibition, and activation, I'm going to pick on you first.
All right. And if I'm being honest, right?
Yes.
When I was in school, we didn't go over this reciprocal, like we didn't touch upon that. So that's what it's getting me.
The reciprocal inhibition was not something that you guys talked about.
Yeah.
Okay, that is fine. But I can tell from the way that you're slow to answer the question that you're also unclear on your agonist antagonist pair. Right. So if I picked a muscle, so if I picked a muscle in the body and said, if this is the agonist, name the antagonist, it probably would be a little challenging for you to do that. So it would be, like we all need to brush up on those. We all need to brush up on those. But for agonist and antagonist, also for activation and inhibition, which is the definition, it's part and parcel of the agonist and antagonist relationship. It's just different words, right? Describing the same relationship in different ways. For those things, you're on my list. So I think we need to, all of us need to practice those. So let's finish up with this reciprocal and autogenic inhibition, and then maybe we'll do some antagonist agonist pairs. We'll do when we'll use words like activation and inhibition. Okay, Khalik, thanks for taking one for the team tonight.
Yeah, no problem.
So now remember that afferent and efferent describe the impulses that arrive at the CNS. Just answer to yourself, which impulses arrive at the CNS? Is it sensory or motor? And the answer is that it's sensory. And which impulses exit the central nervous system? Is it sensory or motor? It's the motor impulses which exit the central nervous system and go to the effector tissues. Those are called efferent, letter E for exit, letter A for arrive. These are a couple drawings that, just because these things can look abstract to people who haven't spent a lot of time looking at them, I just want to go over them with you. So on the right, you see various kinds of effector tissues. Right, so you have skeletal muscles, which we've been dealing with tonight, but you also have blood vessels. So that's both the muscles in the walls as well as things like stretch receptors in the walls of the blood vessels. And then you have all kinds of stuff in the skin. You have pores, you have glands, you have even the roots of hairs, temperature receptors, pain receptors, etc. And some of these receptors are sensory in nature. They're drawn as blue with arrows going toward the central nervous system. This is part of your spinal cord, so this is in the central nervous system. So some of them are sensory in nature, and those are afferent. Letter A, afferent. Sensory impulses arrive in the central nervous system. They're information collected from the sensory organs in the skin or in the blood vessels or in the muscles or the tendons, and they go into the central nervous system. And then the central nervous system has to do something in response to that information. It either stays the course or it changes the course. So if it needs to create a change, it will send a motor impulse through an efferent, letter E down here in red, letter E, efferent neuron. And that efferent impulse will arrive at a skeletal muscle or blood vessels or some organ in the skin. It exits the central nervous system and it causes a response in an effector tissue. Effector tissues can be muscles, they can be hormone gland, endocrine glands, they could be blood vessels, skin, anything. All right. This slide is in gray. Whenever you see any of my slides in gray, it means this information is not something you need for the MBLEx, but it'll help to give you clearer context if you are somewhat familiar with it. Don't memorize anything in gray. Okay. Okay, next is components and characteristics of muscles. So that's how muscles are put together. That's the histology, and then fiber arrangement by pennate structures that exist in skeletal muscle. Yeah, okay. Are we going to do these, or are we going to do? Yeah, agonist, antagonist, synergist, and prime mover is part of a different slide, a different group. Are we going to do this tonight? No. Let me get some more specific examples together for agonist, antagonist, and prime mover that you guys can see, and then we'll go over them. And we definitely should do some of that movement. So now we're on to components and characteristics of muscles. And the first learning objective, or the first study point, is to understand basic components of the muscular cell. That's called histology. That's how the tissues are put together. So muscle fascicles, muscle fibers, myofibrils, sarcomeres, and structures that exist in skeletal muscle as well. We'll do those two first. The effects of massage on the muscular system. There's many effects, but some of the effects, and this is one of your study objectives, some of the effects are that massage will increase proprioceptive accuracy. So the ability to correctly sense the angles, the joint angles, as well as where the body is in space, how quickly things are contracting, how to accurately perceive the load that's being placed on the muscles, as well as muscle strength in athletes who have overtrained. So in people who have overtrained and are suffering from delayed onset muscle soreness or are stiff, their proprioceptive accuracy and their strength, the strength of their muscles, can be improved through massage. Massage also, in all people, increases range of motion and decreases stiffness, increases the blood flow, and increases the temperature of the muscles. Massage therapy also releases trigger points, breaks down adhesions, and frees the fascial bags and the muscle fibers. Those are just a few of the effects. All right, so the organization of muscle fibers in skeletal muscles, identifying the structures of muscle fibers down to the microscopic level. So we're looking at a muscle belly here and a tendon here, and if we cut the muscle belly in half and we look inside, what we see are bundles of fibers. So the fibers are bundled up into here what look like a dozen fascicles. So there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and one behind 11. So let's just say like a dozen fascicles. And each fascicle consists of many myofibers. Am I getting this right? Yeah, myofibers. Myo means muscle. Sarco also means muscle. These two words, sarco and myo, they are interchangeable. I think one is Greek and one is Latin. So myofibers, or muscle fibers, they all bundle up together and they form a fascicle. And then a bunch of fascicles bundle up together and they form a whole muscle. So muscles are made of fascicles. Repeat after me. Muscles are made of fascicles. Fascicles are made of myofibers. Myofibers are made of myofibrils. And then myofibrils are made of myofilaments, actin and myosin myofilaments. Actin and myosin myofilaments. So we have the fascicle, then we have the myofiber or muscle fiber, and then we have myofibrils, myofibril, myofibril. Some of the structures that you'll probably be asked to identify inside of a muscle cell are the wrapping of a muscle cell, which is called the sarcolemma. Sarcolemma. Do I have a picture of a lemma here? A lemma is like the wrapping, the outside of a husk. I'm not seeing it. I guess I don't have it in this one. I think it's in my anatomy, muscle anatomy slides. So a lemma is like the husk, like a corn husk, and on the muscle fiber or myofiber, it's referred to as a sarcolemma, just to confuse you. Sarcolemma on top of a myofiber. Myofibers, muscle cells, muscle fibers, they also have all the organelles that other cells have. So inside here are drawn these little like pink jelly bean shaped objects with like squiggly lines inside. Those are called mitochondria. Mitochondria produce ATP, which is incredibly important for muscle cells. It's important for all cells, but definitely for muscle cells. And also pictured usually are darkish or even black circles or jelly beans or ovals around the outside of the myofiber underneath the sarcolemma. And those are nuclei. This one also has some blood vessels drawn on it. So again, so we have the muscle belly, which is made up of many fascicles. Each fascicle is made up of many myofibers or muscle fibers. Muscle fibers are made up of many myofibrils. Myofibrils are made up of filaments, myosin filaments and actin filaments. And you'll see them referred to as myofilaments, actin and myosin filaments together. There are two types of myofilaments or muscle filaments. It's all, they're using words interchangeably. They're using myo and muscle interchangeably. And it can be confusing, but if you can remember a few basics, like for example, fibers are made of fibrils. Fibrils are made of filaments. If you can just remember that, like practice that much, fibers are made of fibrils. Fibrils are made of filaments. That'll help frame things more clearly in your mind. So the myofilaments, actin and myosin, they are respectively thick. The myosin is thick, and the actin is thin. And their job is to interact with one another to create a muscle contraction. So the thick filaments, the myosin filaments, they have these like golf club shaped heads on them, and they actually they grab the actin fibers and they pull the actin fibers when it's time to contract. So, and ATP makes that happen. Energy makes that happen. So they grab the actin and pull it along, grab the actin and pull it along, grab the actin and pull it along. And the result is that the ends of the actin filaments, which are arranged in kind of a Z pattern. So the area where the actin filaments, one group of actin filaments end and another begins, are called the Z discs. So the result is that the Z discs get pulled towards each other and the muscle fibers actually shorten. Let me see if I have, I should have other, oh no, it's not here. Hold on a second. This is a mistake. I should have this in another. Yes. Okay. We just discussed a little bit of sliding filament theory with the actin and myosin sliding past each other, but that's not a main focus tonight. We'll go over that a little bit more or rather we won't go over it more, like in more depth. We'll go over it almost exactly as we did. We just covered the majority of sliding filament theory that you'll need for the MBLEx, but we'll do that another time, not tonight, because that's a different part of your kinesiology training, not part of components and characteristics of muscles. So again, the basic structure of a muscle is muscles are made up of fascicles. Fascicles are made of myofibers. Myofibers are made of myofibrils. Myofibrils are made up of myofilaments. If we go from small to large, we can say that actin and myosin are types of filaments that make up fibers. So fibrils. Filaments make up fibrils, and many myofibrils make up myofilaments. Myofilaments make up myofibrils. Many myofibrils make up myofibers or muscle fibers. Muscle fibers together bundle into fascicles, and fascicles bundle into muscles or muscle bellies. And if you go to your MBLEx basics document, I have that I have that listed down here. To scroll down a little, a whole muscle is made up of many smaller bundles known as fascicles. Each fascicle is made up of many muscle cells or myofibers. Myofibers contain cylindrical bundles of myofibrils, which in turn contain many smaller bundles of myofilaments. And the thin myofilaments are actin, and the thick myofilaments are myosin. Is anyone like confused or exhausted or just generally cranky right now as a result of the muscle histology?
Yeah, just a little bit.
Say that again.
No, I said just a bit. A lot of information.
Okay. Yes, there is. Do you get the concept that muscles are made up of smaller strands, like increasingly smaller strands?
I'm sorry, repeat that.
Do you get the concept that muscles are made up of increasingly smaller strands, increasingly smaller fibers?
Yes, but this, the slide that you're on right now, it was a bit confusing to me.
Jennifer, the slide we're on right now, you were a bit what?
Confused on.
Okay. Why don't you try walking me through what's on the slide, reading the structures that are in red. So here we have muscle, circled muscle, and then fascicle, and then fiber, sarcolemma, and myofibril. You can skip sarcolemma for the purposes of this exercise.
Okay, so you have muscle,
Yep.
what was it?
And every muscle is made up of
the fascia. What is that?
Fascicles.
very close.
Fascicle.
Fascicle, yeah.
Fascicle.
Fascicle, yeah.
Okay.
And now let me hear you say each fascicle. Each fascicle is made up of.
Each
Yes.
fascicle is made out of myofiber.
Yeah, and I want you to emphasize in your mind when you say it, emphasize the word fiber.
Fiber.
Myofiber or muscle.
Myofiber.
Yeah, or muscle fiber. Yes.
Muscle fiber.
Good. And each myofiber is made up of.
Myofibril.
That's right.
Myofibril.
And now down here, each myofibril, I'm going to go to the next slide so you have a bigger picture, okay? Each myofibril is made up of what? It's also up here. Myofibrils are made of
myofilaments.
Yes. And the myofilaments are made of
Actin and myosin.
That's correct. Now look at the drawing and look at the thick lines and say to yourself, these are myosin, thick myosin.
Are myosin?
Yes.
The thick ones are the myosin. Okay.
Yes. And the thin lines are actin.
And the thin lines are actin.
Right. The myosin and actin filaments, they make up a myofibril. Now we're going backwards.
Okay. So the myosin and the actin make up the myofilaments.
Fibrils.
Fibrils. Okay, myofibrils.
Fibrils, yeah, the actin. Oh, wait, I think you had it correct. You said you just did it differently than I expected.
Yeah.
I think you said the actin and the myosin, they make up the filaments, and that is
Yes.
correct. And then the filaments, the myofilaments make up,
Make up the
Right here.
myofibrils.
right, and I'm going to go back to the previous slide, so you have the big picture again, and then the myofibrils make up,
Fibrils make up the myofiber.
that's right, and the myofibers make up the,
The the fascicle.
yes, the
Myofibers
fascicle,
make up the fascicle.
yes, and the fascicles make up,
Those make up the muscle.
yeah, very, very good, Jennifer. Good. Does it feel a little bit less jumbled now?
Yeah, less jumbled. They're just
Yeah.
like, going back and going back. I definitely am going to be rereading the notes that you have on the drive.
Yes, it is. It is a matter of repetition. You are literally learning Greek.
Yeah,
So
no,
it's like,
it feels like that.
yeah, they can't make it non-Greek, I guess.
Mhm.
Okay, thank you, Jennifer, for your
Thank
time. So
Quick
let's
question.
continue now. Yes.
Do we need to know that car? What was it again? I'm sorry, that car, the one that you had circled with all the myofibril and all that. There you go, the sarcolemma. Do we need to remember that one as well?
Oh, this structure here, the sarcolemma. Yeah, I would. The sarcolemma is around the muscle fiber. So if
Yeah.
you can remember that the muscle fiber or the myofiber is the cell, and it's wrapped by the sarcolemma. The sarcolemma is the cell membrane.
Oh, okay.
That would be
Yeah, the other one,
helpful.
I just couldn't remember that one.
Yeah, I don't think you need to memorize the paramycium or the epimycium. I don't think you need to know those, but it's hard for me to discern which ones are going to be, which ones they will ask you and which ones they won't. But you could try to keep it organized in your mind like this. Epi means like the outermost. Epi is the outermost. Peri is between. So the perimycium would separate the fascicles. The fascicles are made up of the fibers, and the fibers are wrapped in a sarcolemma.
Oh, okay. All right, thank you.
Yeah. Yes. Okay. Moving along. Yeah, this slide here is just showing organelle structures inside the muscle fiber. So you have the nucleus, and then you have the mitochondria. It's also showing the sarcolemma, the cell membrane of the muscle cell, muscle fiber, myofiber. I don't think that you're going to need to know H zones, M lines, I bands, A bands. I don't think you're going to need to know those. I could be wrong. That's part of sliding filament theory. I'm not going to take you through that, but I don't think you need to know those. It'd be good if you knew the Z discs, because the Z discs are kind of the ends of the sarcomere, the ends of the actin filaments. I guess I should tell you that the reason muscles have a striated appearance, the reason skeletal muscles have a striated appearance, is because in some regions, the actin and the myosin naturally overlap. In some regions, they're separate from each other, and it's just actin. And in some regions, there is a combination of actin and myosin overlapping, and that creates a darker appearance, a striated appearance in those sections. Also, get familiar with this term sarcomere. So a sarcomere is like a small section of a myofibril. So a myofibril is made of many sarcomeres stacked end to end to end. Just like the cars on a train, they stack end to end to end. So sarcomeres are stacked end to end, and they form long chains that then make up the full length of the myofibril. And it's the sarcomere that actually shortens. Let me go ahead and show you this video which is from the lecture that we're going to have next time.
You use muscles every day to do activities. This woman is using muscles to breathe, circulate blood, and move her hand to take notes.
I see. Hold on a second.
Your cardiac and smooth muscle tissues are involuntary. You do not consciously control their actions. Skeletal muscle works under voluntary control.
All right, so it looks like, I just want to show you guys the contraction. It looks like this. So there's the sarcomere, that's the end of the actin filaments, right? Forms kind of a Z on the end, and the Z bands, they move towards each other. Right. So these
I see
thick
that.
filaments here, these thick filaments are the myosin,
I see a black
and the
screen.
myosin
I
is,
see a blank screen too.
oh, you see a blank screen? Oh,
Yeah, me too.
can you see it
There we
now?
go. Yeah.
So strange. When I do full screen, sometimes it wigs out like that. Okay, so these thick fibers here are myosin, and then the thin fibers are actin, and the actin connect to this Z disc or Z line. So the Z discs, they mark the beginning and the end of one sarcomere unit. So here's one sarcomere here, here's a second sarcomere here, and the myosin filaments are going to pull the actin filaments and thus the Z discs towards each other. And it looks like myosin. Now it's going to show you the actin. Oh no, we've moved on from that. Hold on. And when they contract, thick filaments pull the thin filaments, myosin pulls the actin, and the two Z discs move towards each other. The two ends move towards each other, they shorten. Okay. The video is available to you in Kinesio Concepts of Muscle Contraction, and the link is up here. By the way, I'm getting the titles of the slides presentations from the guides. So if you go to the kinesiology e-guide, it's set up in sections, right? So components and characteristics of muscles, these 4 study points, they're in this slide here, components and characteristics of muscles. And then if you go, how do I get this annoying thing out of the way? Oh, good, it's just going to stay there. Okay. Concepts of muscle contractions would be in a different slide, right? And then if you keep going, the study points for proprioception are in the same slide. They happen to be in the same slide as components and characteristics of muscles. I could have separated them out, but sometimes I bundle each of the study points. Sometimes I bundle each of the sections to some of the sections together, and sometimes I separate them all out. So I'm trying to be as organized as possible. What I intend is for you guys to look at each individual study guide, for example, kinesiology or pathophysiology or anatomy, and to use each study guide to go over the sections and then to go to the associated presentation. And that way you can look at what it is that we've covered and what it is that we haven't covered. And you can also just go back to things that you want to cover, or you can cycle through things in a way that's a little bit more systematic, a little bit more orderly that way. Okay, so we got a little bit into sliding filament theory, and we discussed the histology of the muscle cell and the histology of muscles, how muscles are organized, and we talked about some of the structures inside of the muscle. Those are all your study points for components and characteristics of muscle. And we also did proprioception. Proprioception is the discernment of where your body is in space. It's the shortening, lengthening of muscles. It's the angle of the joints. And that is all discerned by the muscle spindle fibers, or the intrafusal muscle spindle fibers, and the Golgi tendon organs. It's okay if you guys hear this stuff and you're like, whoa, my God, I have no idea what a Golgi tendon organ is, and we just heard it a minute ago. It takes many times to hear something. It takes many times to integrate something. Repetition is the mother of learning. Okay, so now let's look at demonstrate the ability to recognize muscle by their shape or fiber arrangement, such as bipinnate, flat, or multiple ends. We definitely should do that. The anatomy of a skeletal muscle. Yeah, let's do that now. So describe, this is another study point. Describe the differences between the skeletal, smooth, and cardiac muscle fibers. What I want you guys to know is that there's more than one way of organizing any structure in the body. So you can organize any structure in the body by what it does, that's its function or its physiology, or you can organize it by how it's built, that's its anatomy or its shape, right? And you can look at things from a gross perspective, a big perspective, so the anatomy or the shape, or you can look at things from the microscopic perspective down to the histology, right? And we just looked at the microscopic, like histological level of muscle cells. So now we got to look at the gross aspect of muscles, and that gets into the different kinds of muscles, like smooth, skeletal, cardiac, voluntary, involuntary, striated, non-striated, and all of those are different ways of organizing. So, for example, they can be organized. Muscles can be organized by type. So the types of muscle include skeletal muscle, cardiac muscle, and then smooth muscle. Skeletal muscle is also known to be striated, and voluntary. Those are striated is a morphological classification, and voluntary is a functional classification. Cardiac is striated and involuntary. Smooth muscle is non-striated and involuntary. So that's type: skeletal, cardiac, and smooth. Those are the three types of muscle. There are two morphological classifications of muscle. There's striated, and then there's non-striated. Morphological, like morphing, like changing, like shape. So that's, or appearance rather. So that's striated, and then non-striated or smooth. And then the functional classification of muscles, some are voluntary, some contract voluntarily through our conscious effort, and some contract involuntarily. They don't require conscious effort. It's useful to review the different ways of organizing structures, because sometimes we see like voluntary, involuntary, and we think, oh, cardiac is involuntary, skeletal is voluntary, which is true, but that's just one classification, and skeletal and cardiac are a different classification. So keeping these organized and separated in your mind can actually help you see how everything works together, and on a test, it can make things much clearer for you. Going into the anatomy of, continuing with the anatomy of the skeletal muscle, one of your study points is to identify various organizations of muscle fibers in skeletal muscles. And that gets into like the shapes, also gets into the shapes of the muscles. So every muscle has a belly. It also has an origin, and it has an insertion. The origin is a tendon, and that's a connection to a bone. Usually it's the more stable of the bones. So the rectus femoris muscle connects to the pelvis, which is very stable on one end, and it connects to the tibia, which is very movable on the other end. And it inserts on the tibia, the rectus femoris originates on the pelvis, and it inserts onto the tibia. Is that true? Does the rectus femoris originate on the, it may originate on on the femur. Origin. The rectus femoris originates on the pelvis. Yeah, originates on the pelvis, on the looks like anterior superior iliac spine. Okay. So the origin is the more stable of the two, and the insertion is the bone that's the less stable of the two, the one that moves. Tendons are also spelled, their tendons are spelled ONS and INS. So tendons or tendins are made mostly of collagen, which is white in color. And just a little like interesting thing is that tendons actually are attached to the cell membranes of the muscle cells, or the sarcolemma of the myofibers, and they kind of grow collectively out of the myofibers and bundle up and form these thicker structures. Okay, that's our time for tonight. So next time we're going to go over recognizing muscle by shape or fiber arrangement, i.e. bipinnate, flat, or multiple ends. And they're all listed here, or examples, very common examples are listed here. So if you want to continue to work on this on your own, if you want to study this on your own, you simply go to the MBLEx folder and you find kinesio, proprioception, components and characteristics of muscles. And then you come down to the slide where we stopped, which looks like it's going to be slide number 29. I guess you don't really need slide number 29. Need me to tell you what number slide it is, but there it is anyhow. Okay. All right, guys. So have a great night and a great week. If anybody wants to come to the class tomorrow night, it's the same link. Oh no, there's no class tomorrow night, but I will have class Tuesday and Thursday next week. Also, there's class Saturday and Sunday. Saturday and Sunday is from 11 a.m. to 1. Tuesday, Thursday is from 8 p.m. to 10 p.m. So you guys use the text message thread to ask any questions or to give any feedback if anything's not working for you or if you need help with anything. Also, check your Zoom links before class. Check your Zoom links like the morning of class or, an hour before class. Make sure that you know where it is. That's really 80% of the battle, is making sure you know where your Zoom link is. It's in the MBLEx basics document. I also texted it to you at one point. So, you guys just make sure that you're ready for class so that we can start as close to on time as possible. Nobody's always on time all the time. But we want to start as close to on time as possible. Thanks for
Quick question, will that be
participating.
the same
And
link
yes,
every single time?
always the same link every single time.
Okay, perfect. Thank you.
Yes. Okay. All right. So have a great night. Have a great week. We'll see you on Monday or maybe before. All right. Take care, guys.
Bye.